So we have given the name the clinical grand round because we are going to discuss the cases as we do daily in our rounds, and how with this simple information we can go for the analysis and derive some points which will help us to reach to the diagnosis. Let me start with the first case. Actually, this case I have selected from one of my postgraduates who discussed, I think, in the recent past. This was a 3.5 years old female child by religion, residing in Ahmedabad and belonging to upper lower socioeconomic class as per the modified Kupuswamy classification. I think just I want to remind to the postgraduates, in every case presentation we mention the Kupuswamy classification. But some examiner may be tempted to ask that what is this modified Kupuswamy classification? And many times the students have not given this much importance or attention to this point. But just to remind you that from the occupation of the main person of the family, his education, and his income of the whole family, these 3 points have been considered for the different criteria. And from the scoring, we go for this different category of these families. So just to remind to the student that please, you should go in the details. And here the child presented with distension of abdomen from 6 months of age. If I remind you, the child is 3.5 years old. And the problem, distension of abdomen noted by the parents from 6 months of age. It is almost for 3 years. I think, should I ask that this simple distension of abdomen, how will you take it? How will you try to analyze? What points you will ask to the parents and try to know that what distension is due to what? Then anybody will be able to participate with me from the screen? Dr. Shalab?
Sir, anybody, I request all the postgraduates to please
Yes.
And respond to sir queries, and we make this session interactive. You can unmute yourself and participate.
Yes, without any hesitation, please. Anyway, we know that sometimes discussion in the exams, you know that 4 or 6 examiners. In Gujarat University, there are 6 examiners, some places 4 examiners, but they will start asking the questions because they have to complete in the defined time. You know, distension of abdomen can be the physiological, the younger babies, infants, that protuberant abdomen without any disease due to the laxity of the abdominal wall, or even the rickets, Down syndrome, hypothyroidism, MPS, so many reasons. But once these are the distension, we'll have to see that it is due to what? Is it due to the organomegaly? Is it due to some mass? Or is it due to the really collection of fluid in the peritoneal cavity? And that also we can go in the different way. When the upper part of fullness of the abdomen is mainly due to the organomegaly. And then this uniform enlargement of the abdomen, commonly it is due to the ascites. So let us see what was the situation in our patient. Here it was a complaint of abdominal distension from 6 months of age. It was initially noticed by the father as somewhat big belly compared to other kids, and is considered normal. But then it was insidious onset, progressive, and when the patient had generalized abdominal distension. That was the history of the present illness. So again, which I was talking, that probably it gives us the idea that generalized abdominal distension, if it is acute, it can be intestinal obstruction, it can be some surgical condition, severe hypokalemia. But when of the more than 3 years duration, probably these acute conditions have gone. And so probably it should be ascites also. At the same time, may I request that even the chairpersons and other faculties can also participate so that we can make it live rather than this just discussion from my side only. Sir, do you agree that it is ascites or something else is also possible?
If it's insidious in onset and increasing gradually, ascites has to be kept in mind, definitely.
Right. Sir, can it be some cystic swelling in the abdomen?
As you said yourself, it's a generalized abdominal distension. Now, if we look at the cysts that you are going to get in the abdomen, it may be a highlighted cyst, which is extremely rare. So the first thing which would come to my mind is if it's increasing gradually, insidious in onset, well, ascites has to be kept in mind. Cysts are generally rare, so I would put them low down on the list. I mean, it could be the causes of a generalized distension of abdomen could be many, as you very rightly said. It could be rickets or Downs or MPS, but I mean, looking at the story, ascites comes up at the top.
Right. Can it be some mesenteric cyst or suppose female child that the ovarian cyst at this age, presenting in this way?
It is rare, sir. And then again, the ovarian cyst would present in the lower part of the abdomen.
Right.
We have mentioned a generalized abdominal distension. Ovarian cyst would be there in the lower part of the abdomen.
Right.
And as used to be the teaching that if you're looking at the umbilicus in an abdominal distension due to ascites, the umbilicus is going to be midway between the xiphisternum and the pubic symphysis in ascites. But if it's an ovarian cyst, it's going to be closer to the xiphisternum.
Right.
So these are those clinical points which differentiate an ovarian cyst. And of course, yes, I will put it low down on the list. Yes.
Right. So as Dr. Dayal mentioned that if you go into the details of the story and if you consider that the common possibilities first, then ascites is more possible. Okay. I think those who are not participating, can you mute yourself so that background noises can be avoided, please? When you want to speak, you can make it unmute, otherwise keep it muted. Okay, this was the negative history to rule out the various things. That abdominal pain was not there, no jaundice, no constipation, no vomiting, no emesis or melena, decreased urine output. And for this illness, initially, child was hospitalized at the age of 2 years. And as per the relatives, some fluid was taken from the abdomen. And imaging procedures were done and referred for the further medication. Before that, child was given some medicines for 6 months without any improvement. And in the past history, there was no any significant except this distension of the abdomen, which was gradually progressive. In the family history, this was the second sibling. First is 7 years old and he is healthy, and no such illness in the family. I think antenatal period was uneventful. Birth history was full-term CS without any issue or problem. Birth weight was 3.5 kg. That is very good. It was exclusive breastfeed for first 6 months and no NICU admission also. Immunization as per the national program was given and it was checked that the obesity mark is present. Dietary history, I think consumption was good, protein and calories both.
Sir, please unmute. Sir, please unmute. Sir, please unmute. Yes, sir.
Okay. Am I audible?
Sir.
Is it okay?
Yes, sir.
Okay, fine. So I think in short, if we go the history part, that this was 3.5 years old child, born through non-consanguineous parents, presented with gradually increasing generalized abdominal distension since almost birth, we can say, which was noted by the parents, consulted by the multiple hospitals, and even AKT was given for 6 months without an improvement. Already we have seen that the birth history development, everything was normal, immunized as per the national program. I think here I would like to stop sharing and would like to interact with the friends that what is our thought process. From the history, what we are considering. Always I think what we wish that first the anatomy, that means which part or which system is affected. Second, usually we are thinking that what is the likely pathology. And third, possible etiology. I think keeping in mind, I request all the friends that please put your ideas. Those are on the screen. Please, you can make your video on so that I can see the faces, I will say good, and the beautiful faces on the screen, and even your interactions when we are talking. So please. Gradually, I'm learning that by monologue, it becomes more, I will say, boring, or people are losing the interest. So let us make it, I will say, interesting by interactions. So please, friend, from the history, what is your idea? What is the likely problem with the child? Sir P.L. Prasad, sir, or other friends on the screen, please. Sir, can you unmute yourselves? Prasad, sir.
Yeah, good afternoon, sir.
Yes, sir, good afternoon.
Yeah. It's a very nice case and very nicely introduced. The subject has been introduced very nicely. I have also heard the way you have taken up as the abdominal swelling, and the input which has been given by Professor Dayal is extremely important for everyone to remember, that it appears to be a chronic condition, which somewhere it is definitely ascites. It was tapped, and considering the possibility of tuberculosis, even antituberous treatment has also been instituted without any relief. Now we must go and find out at general examination what is the state of umbilicus, whether it is pushed up, pushed down, or it is still increasing. Is there any swelling in the limbs, upper limbs, lower limbs, or anywhere else, or genitalia involved or not involved? And what all, then only will be able to decide further as to what has happened, because it doesn't appear to be a case of only cystic swelling, such a huge swelling which is giving rise to generalized abdominal distension. So it has to be some problem which is of systemic nature. This is what I feel.
Right. Thank you, sir. Anybody else would like to put their inputs? Suppose if we consider that it looks like the ascites,
yes,
then what are the various possibilities which started or noted by the parents since the age of 6 months? And already one point we have noted that somebody has given the AKT complete for 6 months, but there is no response at all. So keeping in mind these 2 points, what will be our further thought process? Anybody? Dr. Dayal, can you enlighten on this point, please?
So what we know is that it is not tubercular ascites.
Right.
But this leads us to the question that, is it only ascites and with no other edema anywhere else? Number one. Number two, if it's only ascites, then we start thinking in terms of causes of a transudate or an exudate. And if we are thinking first of transudate, then is there any possibility of cirrhosis or anything around the liver region which is pressing on the porta leading to this? So that way I would look at the transudate. Exudate, of course, the tubercular component has been ruled out. Again, in transudate, anemia with hyperproteinemia, they should have some generalized edema. But as you said, that the weight is okay. So now we have to go through the list of causes of ascites and then carry out the relevant investigations.
Right. Anyway, I think fairly good inputs from the friends that apparently we consider the ascites. And the approach point of view, Dr. Dayal very rightly mentioned that if you get the fluid, then first check it with a transudate or exudate, and then various possibilities we can consider. But I think in the absence of investigations, and even the or findings, clinical findings, from only history point of view, if we want to discuss, and I think, in the MD examination, DNB now, most of the examiners are asking that what is your summary and what is your thought process from the history. Then again, when you get the examination, how you modify your thought process, and at least investigations for confirmation. I think the same thing we are following in the practice also. And I'm sure that is a very good exercise. Now the point is that anything started from the age of 6 months, almost probably we can say that even from the early infancy, or even we can say that from birth, pathology is likely. Then the first question we can think that is it congenital or acquired? The pathology. And really some congenital cause, then we'll have to give the thought process. Acquired probably yes, as Dr. Dayal said that cirrhosis of liver. But the cirrhosis of liver presenting when this liver disease started, which already failed and resulted in the cirrhosis of liver, presenting with the ascites at 6 months, probably very difficult to explain. Otherwise, cirrhosis of liver and ascites, yes, we can keep in mind. Or third, it is suppose basically some cyst, and that cystic swelling starts beginning with the small, but as it grows, probably it goes for the globular, and then difficult to differentiate whether it is really cystic swelling or even the ascites. So I think these are the points which I just keep in mind from the history. Should I share the PPT for the examination, sir?
Please go ahead, sir.
Yeah. So an examination patient was conscious, cooperative. I think he has mentioned well-oriented time, place, and person. This is very common mistake by the students. Orientation of time, place, person is not possible before the age of 5 years. So best way is not to mention. You can mention on the contrary activity of the child. 3 years old child suppose interacting with you. If you are asking the name, child is even able to speak out his name or able to interact with the mother. So that gives the idea this regarding orientation, but not straight away orientation of time, place, person. And the child, he has mentioned that apparently it was wasted. Temperature normal, pulse almost 90, it seems to be normal, respiration rate normal, blood pressure normal, saturation normal. And there was no all these findings of anemia, clubbing, cyanosis, lymphadenopathy, jaundice, edema, except this ascites or distension of abdomen. There was no edema feet, no edema face even, and no dehydration, no any sign of hepatocellular failure. Anthropometry point of view, if you see that this weight was 14.9 and more than expected. Height was fairly good, head circumference okay, but mid upper arm circumference is less, and chest okay, and abdominal girth was 63 centimeters. This was a growth chart. Examination point of view, if you see the head, eyes, face normal, neck normal, chest normal, wasting of limbs noted, bones, joints normal, skeletal normal, external genitals normal, spine, hyperextension of the spine and lumbar region. Arterial orifices normal, no visible Jupiter venous pulsation, erectile cirrhosis, no widening of race, that means no rickets, no petechiae. Systemic examination point of view, abdomen inspection, yes, it was uniform abdomen, movements, abdominothoracic respiration. I think umbilicus, everybody was interested. It was centrally placed, everted, transversely stretched. Visible superficial veins, scar marks Mark was noted on left inguinal fossa, skin stria absent, no visible pulsations, groin and opening normal. This is the photograph, just I'm keeping for a few seconds so that you can have the visual impression that when the child was standing, you can see the lordosis, you can see the huge globular abdomen. We can see this position of the umbilicus. You can see that there is no edema feet or edema face, but of course, yes, limbs are vested. These are the findings just on clinical picture. Palpation, superficial, no tense, abdomen was tense but not tender, no abdominal wall edema. Deep palpation, liver and spleen were not palpable, percussion fluid thrill was present, bowel sounds normal, and probably rest of other systems were normal. Again, I stopped sharing over here and to go for the further discussion with this information. Now, what is our thought? I think clinical picture is shown, clinical findings are given on general examination as well as these elementary system. And from that, what analysis will derive and what is our further thought process? Anybody? I want this voluntary participation of the friends, please.
Could you please put the clinical findings, the examination
Yes,
findings once again on the screen?
Sorry?
Could you please show the clinical findings on the screen again?
Okay, sure. This is clinical photographs, is it okay?
Yes, there is some degree of rickets. As you can see, there is rachitic rosary present. Well,
Right.
that I mean, some degree there. And there is no pedal edema. Then the child does look a bit pale, but of course, that is, and as you said, there is no hepatosplenomegaly.
Yes, yes.
So we have a child who looks wasted and has this enlargement of the abdomen with no hepatosplenomegaly. Right. Okay, is there any history of diarrhea?
No, sir. Should I stop sharing?
Yes, please. And the clinical findings, sir, which you mentioned?
Okay. This was, I think, inspection, abdominal distension, umbilicus centrally placed, evertail. Some scar was there with the previous probably tapping. On palpation, no tenderness, abdomen was tense. Liver spleen not palpable. Fluid thrill was present. Bowel sounds present and normal.
What about shifting dullness, sir?
Fluid thrill was present and no shifting dullness.
Actually, if it's shifting dullness, is a more reliable sign of detecting ascites than fluid thrill. And because if we have shifting dullness, then we can be sure that there is fluid which is moving inside. Fluid thrill would just mean a fluid which could be present even in a cyst. So that's why I'm just going to the very basics, whether it's really ascites or it's a cyst now. That's why I'm going into that depth.
Right. I think just for the
Dr. Prajapati, sir.
Yes, sir.
Though you have described that the umbilicus is centrally placed, but if you see the photograph, it appears that the upper part of the abdomen is more distended than the lower part of the abdomen, and the umbilicus is definitely pushed downward. So there has to be some swelling inside also, which is above the umbilicus and not below the umbilicus. It doesn't seem to be very generalized distension.
Right.
And
I think
nutritional part, limb wasting shows that the nutritional part is also we cannot ignore.
Okay.
So some swelling above, maybe some cyst is more chances, and nutritional part, both things are there.
Right. I think on the chat box also, let me see some of the comments. Number one, Madam Alka and other friends have requested the postgraduates. So please, friends, accept the request of the teachers. Please come for the discussion. Postgraduates, very good. And another Ajay Srivastava sir had mentioned that it can be the huge ascites. Somebody has put that it is possible that maybe the malignancy. I think very good inputs are there. Just for the sake of the students, let me explain that in a case of ascites, all the signs of fluid in the peritoneal cavity may not be present in every patient. You know how it starts. Once the fluid collection starts in the peritoneal cavity and it is a free fluid, you know that clinically you can see the flanks are full because you know the fluid will be collected laterally. So flanks will be full. And as the fluid is coming gradually centrally, then with the mild ascites, you will get the septic dullness. That means you start these from the umbilicus to percus. That is, I would say, you will go from this resonant and from that you will get the dullness till the fluid is there. Then you change the position of the patient, and that you get this where the dull note was there. Now you are getting the resonant. And that indicates that the fluid is shifted. But in such a patient, still suppose collection of fluid, the shifting will not be possible. That is usually the moderate ascites. And then you will get the only horseshoe shape. That means only this epigastric region is free from the fluid. The rest of the abdomen is full with the fluid. And when in the huge ascites, like our patient, where the epigastric region is full, even bulging, and in that patient, you will not get the dullness, you will not get the horseshoe dullness, you will get only the fluid thrill. That means you put your palm over the abdomen and start at least to strike on one side, you will get the wave on the opposite side. That is the fluid thrill. And presence of fluid thrill indicates that it is a huge ascites. Of course, as both the chairpersons said very rightly, that in a huge, even the supposed cyst is there, then also you may get the fluid thrill. You will get in a case of ascites also. And in that situation, probably we will not be able to differentiate whether it is really cyst or really the ascites. So I think that's the position in this our patient. Okay, anything else, or should I go for further investigation because we want to go for second case also? Sir, I'm sharing the screen for the investigations. If you see the investigation at the age of 2 years, patient was investigated, CBC was normal, ESR was 24, USG showed moderate to gross ascites with multiple internal septations and echo. Ascitic fluid was drained, showed more than 3,000 cells, 70% lymphocytes, protein 4 gram, sugar 44. And CT scan even was performed. It showed gross ascites, internal thin septa with coarse displacement of bowel loops. And patient was referred to our center with possibility of Cox abdomen. Even they considered that multidrug resistant tuberculosis can be there. But when the tuberculosis is not proved, best way is not to think for the MPR. Patient was second time admitted for abdominal tapping, and you can see the report that cells 4,000, protein 4.68 with the serum protein 6, AFB was negative, gram stain negative, EDA was raised, culture negative, and CBNet was negative. Viral markers for hepatitis were negative, liver function test normal, PTAPT normal. USG abdomen showed again multiple septation with loculation. It was diagnosed as a little bit discussed abdominal tuberculosis with tuberculous ascites, with PM with mild iron deficiency anemia. AKT was given for 6 months, which a little bit discussed. Child was referred to the pediatric gastroenterologist, and the investigation showed again CBC normal, ESR 26, CRP normal, PTA-PTT normal, Alpha-fetoprotein was normal. CT scan again showed gross ascites, no vascular malformation, liver spleen normal, and no evidence of malignancy. Patient was then referred to our college GCS. And I would like to remind to the friends that now transudate, exudate, that again the concept is gradually changing. Go for the SAG, that is the serum ascitic albumin gradient. And if it is less than 1.1, which was in our patient, and that means it indicates one of the exudate. And if it is more than 1.1, it indicates the transudate. And CT scan report was performed. Our radiologist reported that possibly intraperitoneal lymphangioma is possible. Ascitic fluid cytology, at least again, no malignant cells were seen. This is just table for the investigations which already discussed, that the renal function, liver function is normal. Even the LFT was normal. HIV, HBsAg, HCV normal. And already I discussed this chemistry of the fluid. And SAG, if I say, that is serum albumin, serum ascitic albumin gradient, which was less than 1.1. And patient was referred to our I would say main institution, BJ Medical College, in the pediatric surgical department. Child was operated and the cyst was excised, and histopathology showed that it was the lymphangioma. And this is the picture of the patient after the operating, quite comfortable and playful. So I think before I go for the second case, let me stop sharing. So ultimately, this was the follow-up of the patient after the operation and histopathology report. So again, what was my idea of sharing the case, that we can start thought process in this way, that almost the pathology started from the early infancy. So rather than some disease process like tuberculosis, some infection, it is very much possible that some congenital reason is possible. Or Indian childhood cirrhosis now we don't see, which we used to see in the past, that remains, I think, one of the possibilities. But if we consider it this way, then probably, and you know, this is another thing, that nowadays with this National Elimination of Tuberculosis Program, it is very dictum that on just our clinical impression or some of the evidences, we are not allowed to start the AKT. We should have the evidence for the tuberculosis etiology. So I think that's another point which I would like to mention. Before I go for the second case, any comments from other friends or the chairpersons on the screen, please?
Can I make a comment?
Yes, madam, please, yeah. Most welcome.
It was a very interesting case, sir. And I think there is one very, very important thing which I think the postgraduates should understand is that there was a massive ascites, in fact, out of proportion ascites without any organomegaly, which should always tell them that it is non-infectious. And it is a pathology which is intra-abdominal secretory kind of a pathology. And especially one very, very important thing to notice is there is absence of edema, pedal edema. Otherwise, if it is associated with wasting, if it was edema, then we should have thought of something else. But since it is without any hepatosplenomegaly, without any lymphadenopathy, if there is such a massive ascites, then it has to be some kind of an intra-abdominal pathology, which is probably secreted. This is my submission, sir.
Thank you, madam.
It is non-infectious. It appears to be non-infectious.
Absolutely the good thought process. And I think that's the message to the postgraduate, that always think in this way for the proper analysis. Thank you very much, madam. Dr. Shalabh, should I go for the second case?
Yes, sir. Yes, sir. Please, sir.
I'm skipping the second case. If time permits, I will go, but third case I'm taking. This was again almost 3 years old child, an illness of 10 months. If I remind you that the illness of 10 months in 3 years old child, not even the complete 3 years. And the main complaint was cough and fever off and on. And child was hospitalized for 3 times. in this 10 months time. If I provide you the further information, the first hospitalization, you can see that hospital for 6 days, hemoglobin, mild anemia, count normal. Chest X-ray showed the right upper zone pneumonia, which I will show you the picture. Child was given the anti-tuberculosis therapy for 9 months. Second hospitalization, again, USG abdomen was done, which was reported as normal. This is a case which I selected when serological tests were done for the tuberculosis, which showed the positive. Chest X-ray reported as right upper zone, mid zone haziness, indicating collapse with consolidation. Suspicious granulomatous lesion, likely Cox with secondary infection. Continued AKT. This was the impression of the radiologist. And third admission, data I have put over there. This is an old case almost 10 years back. CBC almost normal, immunoglobulin is normal because somebody thought of primary immunodeficiency disorder. HIV was negative. Again, chest X-ray was reported as poorly dissolving pneumonia, right side collapse consolidation, obstructive collapse. Now, let me show the picture. This was the chest X-ray picture, which was almost, I think, every time similar. I'm keeping this picture for a few seconds or a minute. Please, everybody should go in the details. First, we'll discuss the chest X-ray picture, and then we'll go for further discussion. That what is your interpretation of the chest X-ray? Please, I want the attention of everybody on the screen, please. I hope that all the friends have seen the picture. So let us discuss from this point that almost less than 3 years old child, in less of 10 months, main complaint cough and fever, 3 times hospitalized, treated with various drugs, antibiotics, even anti-tubercular therapy given for 9 months, chest X-ray, USG abdomen performed, some investigations were performed, and chest X-ray picture which I showed. I have not put all the 3 pictures, but almost it was similar all the 3 times. I think first we can go for this chest X-ray interpretation, that what is our impression, and then we can incorporate the history part, and then we can think for the various possibilities. I request somebody to take it. I think here I'm a little bit not familiar with the students. Otherwise, I will catch the students by name and make them to speak something. I think, I hope that I will visit Dr. Salah frequently to you so that I become the familiar with the students. And you know that being the pediatricians, all of us know that usually child is not reactive to the unknown person. But when it's gradually becomes a familiar, and probably then without any, I would say, agitation, they speak very easily. So I think that barrier, I would like to break it. Okay, meanwhile, who will take it? Or should I go further?
Students, please interact.
Yeah.
I can see Dr. Vidur Mathur is there, Rakesh Shetty is there, Dr. Sonu is there. Some of you should speak up. Then there is a...
Madam, thank you very much for sensitizing them, please. Yes, I think you are playing the very good role.
So Dr. Vidur Mathur is...
Vidur Mathur is put on the screen. Recurrent pneumonia could be indicate the primary immunodeficiency disorder. Very good. But you know, I hope that this Mathur is postgraduate students or consultant. Madam?
These 3 I named were postgraduates.
Okay. Then for the postgraduates,
second year.
Yeah, I can take the liberty when I'm talking to them. I will have the limitations when I'm talking to the consultant. Dr. Mathur, I would like to remind you that what is this recurrent? definition of recurrent pneumonia, that at least more than 2 times in 1 year or so, and more than 3 times at any time in the life. And for recurrent, we have the radiological evidence that this already picture was clear. And then again it happened. Then we can say recurrent. And suppose if it is same picture 2-3 times, we call it as the persistent pneumonia. And I'm sure that the postgraduates will be asked this question, that what is the recurrent and what is the persistent. So now with that idea, Dr. Mathur, what is your idea? It's a recurrent or persistent? Please put on the chat box if you are not able to participate on the screen. I am looking at the chat box also. Yes, 2 or more pneumonia in 1 year. Dr. Mathur is Vidur Mathur. Yes, you are right. Absolutely right. Persistent, okay. Dayal sir, should I request you, please? You can take it.
Yes, sir. Could you show the X-ray once again, please?
Yes, sir, sure.
This is a slightly rotated film. And if this film has been there in all the episodes of pneumonia, then that means the pathology in the right upper half of the chest has not resolved, number 1. Number 2, the rib spaces are widened on the right side as compared to the left side. Well, a part of it could be because of rotation, but definitely there is widening.
Absolutely, sir.
I cannot see the carina very well. So one possibility of a foreign body remaining there could be. Then again, there is this dot-like structure, or I mean, it's not a coin lesion, it's certainly not, but a dot-like structure in the right upper zone. A little,
Yes, sir, you are talking.
A little lower side, sir, a little lower, and on the left side now, on the right side of the patient. Exactly here.
Here you are talking. Okay.
That's right.
Right.
So with this, and then the ribs, I mean, definitely there's widening, the pathology is persisting.
I think what sir is showing, that if you see this rib and this rib, that distance, and if you compare on this side, definitely it is increased. Agreed, sir.
And this ball-like structure there, yes.
Yeah. Okay.
I cannot see the carina, which.
Yeah, it's not visible.
It's not visible.
Not clearly visible, agree.
So that means the pathology is persisting there. And again, it's a pathology which is persisting, and this could be the focal point of pneumonia persisting or recurring, whatever terminology we use.
Yes, sir. At least sir has brought out the good points.
Again, as far as tuberculosis is concerned, it was only the serology which was done. The CBNAT was not done.
Sir, I think this was the 10 years back, and probably CBNAT we were not doing.
Not there. Right.
And that's why instead of the CBNAT, they have done the serological test. Now serological tests are banned for the information to the postgraduates. Dr. Raj has mentioned that the cyst or mass compressing the right bronchus leading to the collapse. Dr. Raj, can I request you to come on the screen, please? With your video on. And whatever I think you are thinking, you can share with us. Dr. Raj has put that is cyst or mass compressing the right bronchus leading to the collapse. That is the thought process of Dr. Raj. May I know that Dr. Raj is practicing pediatrician or postgraduate? The point is, why considering that he's thinking laterally. Thus, we are thinking in the same direction. That pneumonia, recurrent, persistent, but he's thinking something away from this. And he's thinking that maybe some mass or cyst and compressing. And if I just remind you with this point what he had mentioned, persistent cough is the main complaint. And cough is there probably to indicate that it is irritating to the airway. And irritating the airway, that means some compression to the bronchus. And that compression can be to the lymph node, tuberculosis, lymphoma, anything, or maybe what he has put there, some cyst or some mass. So I think it's a good idea. In the direction. Agree. Okay, should I go further? Because
I also, yeah, Prajapati sir.
Yes, sir.
I also
Sir,
agree
please.
with Professor Dayal sir that it is a persistent infection which is persisting there even after treatment for so many 10 months. So it could be, we have seen many cases of foreign body like this where the cough is there and something is obstructing it, and therefore the child is having such pneumonia persisting. So I feel that we have to first think of foreign body in this case. Only thing, the onset has to be, again, in the history, it will come out how the cough started and what was the onset. That will also give us some clue.
Yes, so I think this is a very important point for the postgraduates. Please, what sir has, both the chairpersons have contributed. That the age we are talking of are about 3 years. And that means illness of 10 months. That means the problem might have started at the age of 1.5 or 2 years. And that is the right age for the foreign body. So as I think the pediatrician always will have to keep in mind. And what Dr. Prasad mentioned is retrospectively, we should ask the parents the onset of the cough, that how it started. Definitely, sir, I think very valid point. And therefore, what usually we are teaching and even looking in the practice, that any toddler, when even without any illness, suddenly starts with the choking or the cough, think for the foreign body. And that is the most commonly, I think most of the times we are right. Therefore, always what, even if I remind you, our Ambedkar sir, what we consider that the very good teacher in our country, he always insists that any symptom, ask the parents the onset, how it started, and that will give us the idea. Any cough, suppose tuberculosis, it will not be sudden onset. It will take some time, 2 weeks, more than 2 weeks, 3 weeks, 4 weeks. The foreign body, previous moment child is normal, next moment the child is a very bad cough. So that becomes, I will say, a very valid point. Or another what Dr. Raj also mentioned, that cough is going on, maybe some complaint. That means either in the airway, like foreign body or some pathology, or outside, probably something compressing. These type of the thought process, probably what we are making, is definitely quite feasible, quite palatable. Yes, I think Dr. Piali is seen on the screen. Madam, please, can you come on the screen to help us? Let me share further.
In a moment, sir. In a moment, sir.
Thank you, madam. Now with this X-ray, let me go further. Early thoughts that we discussed. This USG thorax was done by the pediatrician before coming to us, and he said it's an organized thick pleural fluid. Friends, you know that even the modality, how it is making us the food. CT scan thorax was done outside, which was reported as lymphoma. This is lymphoma. Somebody said thick pleural fluid. And antenatal in everything was normal. On examination, weight was 9 point something. That means nutrition is not that bad. Vitals normal. Right side air entry diminished. Cardiac findings normal. Liver 1 centimeter. That means nothing much on the examination. Investigations, if I give, count was almost normal. Platelets normal. Acute phase reactive CSR, CRP normal. Electrolytes, everything was normal. And again, the chest X-ray, same picture. I think now what can be the various possibilities? Anybody? I want to stop the sharing. Almost even in spite of all the investigations, you can see that not helping much, count and everything normal. Even ESR, CRP normal. Chest X-ray, even after 10 months, same picture. Not even the totally changed, but we can see what we are depending upon the investigations. what I want to even sensitize the students, that some not necessary investigations are helping you, making sometimes fool. You know, USC person said it is a thickened pleural, and the CT scan person said it's a lymphoma, and our X-ray picture is showing persistent right upper the opacity. Now, what as a clinician we can do? And all of us are practicing. Parents will ask us that now what further we should do. We are coming to you every time. Whatever you said, sonography, CT scan we have performed, and still we don't have the answer. Anybody that what we should do now? Further investigation? CT scan भी हो गया अभी तो क्या करेंगे?
Should we go for bronchoscopy?
Yes, I think that is good idea, sir. Absolutely right. Bronchoscopy. You can see for the foreign body. You can see the airway. Even you can suppose something pressing over, you can see. Or even you can take the ball, send the material for tuberculosis or AFB or even the Seminat, absolutely. And it will help us. CT guided biopsy, Dr. Raj has mentioned. Yes, biopsy from where, Dr. Raj? From that particular lymph node, okay? I thought that by mistake, hurriedly, I showed it for a second, this next slide, which I didn't want to show. But already one slide, I went ahead. What actually I wanted that, let me share with you. Many a times, okay, somebody has said drug-resistant tuberculosis. But you know, we don't have the evidence of tuberculosis. And this is another point which I would like to bring to the notice of our friends. In the practice problem, we are doing the same thing. My students in the round, sir, it's not responding enteric fever. I said, how we diagnose enteric fever? From Vidal, I will say Vidal is not the answer to this weather. If it is culture and culture positive, then you can say yes. If you say the AFB, here I think we don't have the diagnosis of tuberculosis. It's a presumption. From presumption, we cannot go for the MDR. So I think that's another thing in any case, whether the enteric, whether this tuberculosis, or whether even the UTI, from the presumption, we cannot go for this MDR. We'll have to prove it. Here we don't have the diagnosis of tuberculosis. Anyway, friends, the patient was referred to me from Porbandar. You know that Porbandar is far away from Ahmedabad. It's the birthplace of Mahatma Gandhi. And when this patient was referred to me, I was thinking, and simply, I thought that where the opacity is sitting, nobody is answering. CT or this sonography, let me go for this lateral plate. And this was the chest axis, the lateral plate. And you can see what I want to share with you. That you know that anteriorly, this is totally normal. This is, I think you are able to see the trachea and then the bifurcation. This is the sternum. This is the cardiac shadow. And this part is totally normal lungs. Here again, lower side, if you see totally normal. The opacity is posterior. And it is in the posterior mediastinum. So probably it is not even in the lungs. And therefore, what actually I want to share with you, go for this Cunningham volume, this anatomy. We know that this is the superior mediastinum. Sorry, yes. This is the superior mediastinum. This is the anterior mediastinum, middle mediastinum, posterior mediastinum. And then what we did, if you go for the anterior mediastinum, what are the common structures? It's the thymus, which can be normal or abnormal. Can be the lymphadenopathy. Absolutely, somebody was thinking tuberculosis, lymphoma, leukemia, histiocytosis. Thyroid can be there, retrosternum. Even teratoma, if it is from the birth. cystic hygroma, hemangioma. So I think if I get it anterior opacity, these are the various pathologies are possible. In our case, it was not anterior. Middle one can be the lymphadenopathy, bronchopulmonary foregut malformation, and therefore bronchogenic cyst can be there, or vascular anomalies. But this posterior can be the, particularly if I remind you anatomically, sympathetic chain is there. And with that, even it can be the neurogenic tumors like neuroblastoma, neurofibroma, or neurolemoma. And we concentrated that posterior, this lateral X-ray plate is indicating posterior pathology, not in the anterior or middle, this mediastinum. And therefore, as somebody showed very nicely, we went for the histopatho-operative specimen. These were the various pictures. Friend, just I want to share with you, it was the case of ganglioneuroma. And this patient was operated, ganglioneuroma. And after this surgery, the patient was fine. Friends, what actually I wanted to share with you, particularly for the postgraduates. In the modern era of the time, probably our old method of teaching of clinical medicine is getting gradually rusted. People are not interested to examine the patient for liver or spleen or the lymph node. They are not interested to listen the murmur. They are always asking for the echo. They don't go for the CNS examination. They are interested for the CT and MRI. And here, if I give the example illustration, sonography was done, CT was done, how we were misguided. But simple lateral plate and basic thinking, that lateral chest X-ray showed that the pathology is in the posterior mediastinum. And then posterior mediastinum structure, if you see that posterior mediastinum esophagus is there, lymphatic duct is there, thoracic duct, what we say, and even the sympathetic chain. And then the pathology originating from this, if you try to think, that probably can give you the answer. This is an illustration which I wanted to share with you for the basic thinking, rather than going for the just advancement technology, not necessarily every time it is helping us. Dr. Shalab, is it possible to take 5 minutes for one more case?
Yes, sir.
Okay, only I think 5-7 minutes. And again, to give the message that how we can reach the diagnosis. This is again 5 years old male child, illness of 6 months. I want to sensitize the students for analysis of the, I will say, basic information. Illness of 6 months and that in the form, again, distension of abdomen and vomiting occasionally. Decreased oral intake 3 months. Here, there was the edema fit also with the distension. And child was complaining of generalized weakness. And that weakness reached to that level that now even not walking since 1 month. And when child presented to us, claw hands since 20 days. Child was consulted by the family doctor initially, then pediatrician at Udaipur because this patient was from Rajasthan. And then Modasa, it's a town in Gujarat. And child was treated with the antibiotics, anti-amoebic drugs, anthelmintic, enzyme preparations, and somehow probably nobody missing the anti-tubercular therapy. And consulted by the pediatric surgeon at Ahmedabad. And he advised for repeat laparotomy. First laparotomy was done in July 2009. I want to stop sharing and want the discussion with the friends that what is wrong with this patient. Already one laparotomy is done in Ahmedabad. And this pediatric surgeon again advised that the is some problem of obstruction and we'll have to go for second laparotomy. And child has a distension of abdomen, decreased appetite, even the weakness, and claw hand. You know that this carpopedal spasm, what we say. I remember almost probably 10, 15 years back that when the patient presented to me by medical college, the students talked to me that, sir, this type of claw hand remains with almost constantly since 15, 20 days to the child. Simply, anybody can interact with me that what does this claw hand indicates? Due to what? Yes, Dr. Stuti, very nicely, I will say putting on the chat box, peripheral neuropathy with GIT involvement. Absolutely, absolutely. So what peripheral neuropathy due to what? And what type of the GIT anomaly or problem? So Stuti, can you, I think, why are you not coming on this screen? Yes, somebody has put from the Department of Pediatrics malabsorption. Agreed. I think gradually as I'm teaching to the multiple groups, I am learning that it's not so that the students or the practicing friends are not knowing. They are knowing, they are not speaking. And somehow probably they remain away from the discussion. They probably due to their shyness or probably due to some hesitancy, reluctancy. But I'm sure that once they start to speak, they speak very rightly. Definitely. And I have seen that when we are discussing 4 or 5 faculties on the screen every Tuesday, even I am learning, not teaching, to be very frank, because some faculty speaking, then I realize that, yes, this is not right, comparatively the thing which I was thinking. And when I think multiple friends are there on the screen, the thought process are always there. So very rightly said that some malabsorption, but I would like to know from the postgraduate that what malabsorption, what GIT problem, what neuropathy, and why patient is presented with the claw hands. Who will explain me, please? Anybody can, please.
Sir, malabsorption of protein might have led to abdominal distension and pedal edema.
Mm-hmm.
And malabsorption of calcium or vitamin B12 can lead to claw hand.
Yes, madam, I think you will know that the claw hand or just simply we say carpopedal spasm, probably rather than neuropathy, it is calcium deficiency, am I right?
Yes, sir.
Because you know that the neuropathy usually rather than the claw hand, child will have the complaint of peripheral neuropathy in the form of the tingling, numbness, some pain, or not able to catch the object properly, or even when child is having the slippers or chappal in the legs, even not able to keep the proper grip. This type of the manifestations commonly with the neuropathy.
Yes.
But absolutely what you say, then how we can say, that means we understand the carpopedal spasm due to the calcium deficiency, but how we can explain the calcium deficiency in this malabsorption?
So due to deficiency of vitamin D,
Okay.
can be one cause.
Okay, I think if I tell you, we see plenty of patients of rickets and even the very significant and low vitamin D. I think now all these senior faculty will also agree with me that we don't go for the vitamin D for ourselves because most of the time it is low for most of us because we are not moving under the sun. But you know that even severe vitamin D deficiency, they don't develop this claw hand or that severe hypocalcemia. So is there any other explanation? I agree with you that I will continue the link with you, or I will give some points clue to you that yes, it is related to the malabsorption. But how? Very good point. Just to give the idea to the students and other friends that it definitely carpopedal spasm is calcium, very classically, I think, old teaching to us. Now, calcium is in the body in 3 forms, either in the bone, either in the ionic form, or bound with a protein. When in the malabsorption syndrome, any malabsorption, Protein itself is low, calcium is not able to remain in the bound form. And therefore, hypocalcemia in any patient of hypoproteinemia is quite possible. Take the example of nephrotic syndrome. Take the example of malabsorption, the chronic diarrhea. So I think that's the thing that absolutely now right, our way of thinking. What Madam said is that's having some malabsorption, therefore protein must be low, and therefore pedal edema we can explain. And therefore probably calcium is not able to retain in the body with the albumin, and therefore hypocalcemia, which resulted for this claw hand or tetany like that picture. That we can explain. Absolutely right. Should I go further to save the time? Because I'm afraid of Dr. Shalab because we are overshooting the time. Okay. Here then child was hospitalized 3 times before coming to us. And laparotomy was done in July 2009 for subacute intestinal obstruction, which was diagnosed by the pediatric surgeon. In 2010, again, after 1 year, unfortunately, child developed the falciparum malaria. During that time, falciparum was very common. With severe anemia, hypoproteinemia and edema, treated with antimalarials, Paxil volume, FFP, diuretics. And just 20 days back, also child developed the distension of abdomen vomiting, consulted by pediatric surgeon advised for the repeat laparotomy. In the history, there was tuberculosis diffusion to the grandfather, and he's on anti-tubercular therapy since 5 months. HIV to father who died 1 year back. The rest of the history was non-contributory. So I think from this information, anything else would you like to consider? Tuberculosis to grandfather, HIV to father who died 1 year back. And 3 times he had the problem. Once laparotomy was done. One with a severe anemia, developed this severe anemia, hypoproteinemia, falciparum malaria. Can you correlate what things are going on with the child? Any further idea? Yes, can't it be? Okay, Madam has put the dependence contractures. I think dependence contracture is, Madam, quite different. It will be localized to only one extremity. And that is rather than this hand, it will be more with the upper arm, forearm dependence contractures. But agreed, I think it's a different point for thinking. It's a good idea. Coming back to our case. Now on examination, when patient came to us, vitals normal, pallor was there, no icterus, claw hands, more on the right side. Edema feet, no lymphadenopathy, abdomen distended, soft liver once centimeters, spleen not palpable. There was no ascites. Peristalsis were present and healthy scar over the abdomen, which was with reference to laparotomy, which was done in the past. Other cystines were normal. I think just to save the time, hemoglobin was low, count and platelets normal, RBS, creatinine, SGPT was mild raised, sodium normal, potassium low, chloride okay, calcium 7.2, ionic low significantly. Alkaline phosphatase was raised, very clearly indicating the rickets. And parathormone was raised, cholesterol normal, protein was low, albumin particularly low. EBG okay, urine calcium creatine ratio normal, CSF normal. And chest X-ray was normal. X-ray, these showed the classical rickets. Abdomen showed mild hepatomegaly with minimum lateral fluid, interbowel fluid, sorry, and mild dilated bowel loops. HIV was negative. Again, you know, this is the thing which I want to share with the postgraduates. That from the history and examination, what are the very characteristic points you have noted, put on the paper. That will give you some clues, some thought process. Here in our patient, if you see the distension of abdomen, vomiting is the complaint, failure to thrive is the problem, anemia because hemoglobin is only 6 grams, in the past also required the PCV. Hypoproteinemia we have seen, decades is seen. Tuberculosis is less likely because already AKT given, HIV negative. So very rightly was Madam was saying this malabsorption, proteolytic enteropathy. Tuberculosis, HIV already excluded, and therefore patient was from Rajasthan. So I thought from the Siljar. We went for the serological test, tissue transcriptome significantly raised. Endomycin antibody was positive. Anti-glidin antibody was quite high. I remember that this patient was related to some servant working in Maulana Azad Medical College, Delhi. I referred the patient to Dr. S.K. Mittal sir. Mittal sir did the biopsy and turned out to be the celiac disease. And later on, when I was following to the patient, gluten-free diet, you can see that the child is growing very well and even the gaining the weight. And these are the figures for follow-up that how the child is responding to the line of the treatment. Friends, I stop sharing over here. But what actually I wanted to give the messages to the postgraduates and our friends that even in this modern era of advanced technology, and probably which may be more advanced in the future, please don't try at the cost of the basic clinical medicine. Many times we have learned that the technology may fail, but your basic clinical medicine hardly fails. The only thing that it requires hard working. It requires the detail of the history, very thorough clinical examination, which requires time. Ultimately, we'll have to go to put all the points on the paper, go for the analysis, try to correlate, derive the possibilities, go for the investigations. Investigations, if not helping, go for the second set of investigation according to your thought process. And I think this exercise is quite rewarding, not only in the MD examination, but in the practice also. I think this is the thing which I wanted to share. I hope that the purpose is served. Thank you very much, friends. Again, my chairpersons, Dr. Rajeshwar, Dayal, and Dr. Prasad, for chairing this session and giving this opportunity. And of course, the office bearers of AOP UP branch for giving me this opportunity to interact with the students and practicing friends and senior colleagues. Thank you very much, friends. Now over to you, Dr. Sarah.
A final word from our honorable chairperson, sir.
I fully endorse what Dr. Prajapati has said. Investigations can go wrong, but clinical findings and a good clinical examination always are very rewarding. I would like more of such programs to be held, and I really congratulate the organizers for organizing such a lovely session. Thank you.
Prasad,
Good
sir.
evening. Yeah, good evening, Dr. Salab, Dr. Prajapati sir, and Professor Dayal sir. It has really been a very nice experience, and listening to seeing three cases and how we have evolved to the diagnosis. Like in the second case, I must say that everybody forgot about the lateral chest X-ray, which is very, very important in any chest X-ray where the opacity is persisting. I think we must go systematically and will never lose. We always come to the correct diagnosis. And the third case also, history is always important. We have to devote some time to take history, and then only we'll be able to reach to a diagnosis. Thank you so much, sir, Prajapati sir, for a nice case. And also I thank Dr. Salab and UPIIP President and everyone for giving me an opportunity to be here. Thank you so much.
Thank you, sir. And I think we all know that how good an acclaimed PG teacher and a passionate teacher Dr. Baldev Prajapati sir is. And this is our benefit of our postgraduates, that he has presented three very stimulating cases and has generated a lot of discussion, very making a session very interactive. I think, sir, it is as you told that familiarity. Yes, the postgraduates here are not that much familiar with the interactive way of teaching. If you happen to be visiting here a platform and teaching the postgraduates, I think they will be more interactive in future. And I really thank for your taking a busy time from your schedule, sir. And I'm very much thankful to Prasad sir for his all his deliberations and inputs out of taking time from a busy schedule. We are privileged, sir. And Dayal sir, who was very busy and has to reschedule his program to be here as a chairperson. We are honored to have you as our chairperson, sir. And Dr. Ajay, are you there? So with this, I think the postgraduates must have learned the power of what is the basic history taking and examination, the art, the old art, which is now being forgotten gradually, and the old teachers, masters, teacher of teachers like Dr. Baldev, Prajapati sir, Dayal sir, and Prasad sir. And they have really means the postgraduates will be finding it very useful. And I think this is what of kind of sessions which will help them a lot in the examination. I look forward for the many more sessions with all these stalwarts, Prajapati sir, Dayal sir, and Prasad sir. Thank you so much, sir.
Thank you.
Can I make one simple comment?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Prajapati sir, we were always taught by our teachers, treat the patient, not the investigations. And a clinical
Yes, yes.
examination was something